please feel free to type your questions into the Q&A box. In addition to that, if we have the global interpretation services, so please feel free to utilize that. We have multiple languages here today. To utilize that function, you will see a global bar and down in that global icon on your Zoom bar. You could click that to see the various languages that we have today. In addition to that, we do have American Sign Language as well. So please utilize those functions. This recording will be, this webinar will be recorded and posted on our county website. So with that said, I have the honor and privilege to pass it over to our amazing moderator, Kim, to introduce our panelists and start our training for today. Thank you, everyone.
Kim, you're muted.
Welcome, everyone. For our purpose, our number one is we want to learn about COVID-19 and the latest updates on the vaccine. Number two, we want to gain knowledge and skills to provide key messages, addressing concerns about the vaccines in the African American community. And number three, we want to provide you with communication tools to have effective conversations. And number four, change the conversation around vaccine to the one of choice. Now, why you matter? Because you can have a significant influence on the vaccine acceptance or hesitancy. If we all become influencers, we can achieve community immunity. Let's take care of each other, our families, and our community. And I want to thank you for all being here today. So as we go through our agenda, I'm doing the welcome. And we're going to talk about the COVID-19 cases, deaths, vaccine rates with Dr. Owen. And then we're going to have vaccine updates with Dr. Gates. Then we're going to go into how to effectively communicate about COVID-19 vaccines, and then the next steps. So again, welcome. Thank you for taking the time out of your day to join us. And again, why are you here? As a vaccine influencer, you can help our communities gain confidence in their vaccine choices. Learn COVID-19 vaccine facts and take back talking tools so you can take that back to your community. Why are we here? To equip trusted community leaders like you with the necessary resources to provide clear and accurate and consistent information regarding this vaccine. To build trust and vaccine confidence, dispel vaccine misinformation, and encourage vaccine uptake. Change the conversation around vaccine to the one of the choice. So we have coming up is Dr. Micah Owens. Dr. Owens is a pediatrician with UCD Health and a consulting physician with Sacramento County Public Health. Micah's primary role is providing technical assistance to Sacramento schools as they work to return to in-person instruction, which is what we're going through now. So at this time, I'm going to transfer this over to Dr. Owen.
All right, good afternoon, everybody, and thank you. You can go to the next slide. So before I start, I will give a warning that I do have a child, 4 years old, who is sick from daycare, actually waiting their COVID test. So you might see her pop in and out of the screen here, but we'll do our best. So good afternoon. Like Kim said, my name is Michael Owen. I'm a pediatrician with UC Davis Health in Sacramento County Public Health. And I do work mostly on providing technical assistance to schools as they focus on how to reopen safely here in Sacramento County. Today I will be starting us off by reviewing some of our local data regarding COVID-19, including cases, deaths, and vaccination rates. Next slide. So this is data as of August 13th, 2021. So since as of August 13th, there has been about 618,000, there have been about 618,000 deaths from COVID-19 in the United States, and about 1,800 deaths in Sacramento County. And there have been about 36.4 million confirmed cases of COVID-19 in the United States, and about 122,000 cases in Sacramento County. Next slide. Now I'd like to look at some of our local data by race and ethnicity. And so these graphs show Sacramento County COVID-19 cases and deaths by race and ethnicity. And so rates are per 100,000 individuals. And on the right, we see significant disparities in case rates by race and ethnicity, with Black individuals having a case rate of nearly 6,200 per 100,000, which is significantly higher than most other groups. And on the left, we see death by race and ethnicity, with a major disparity in deaths noted for Native Hawaiian and other Pacific Islander. Next slide, please. So the numbers on the previous slide were since the beginning of the COVID-19 pandemic, and that doesn't necessarily tell us a lot about where we are now in terms of new infections and deaths. So we took a snapshot from last Friday, August 13th, and this is what we saw. So for August 13th in the United States, there were about 141,000. My daughter reminds me that it's the United States of America, sorry. There were about 141,397 newly reported cases and about 691 newly reported COVID-19 deaths. Here in Sacramento County, there were 606 newly reported cases and 3 newly reported deaths. And with this information, it's important to point out that nationally, people are getting tested much less than they were at the peak of the pandemic. So even though we are seeing a local and national surge, since people are not getting tested as much, it is likely that the incidence of new cases is actually higher than these numbers indicate. Next slide. And in terms of recent trends here in Sacramento County, we can see that our number of cases and our 7-day average has been steadily increasing since July 2021. Next slide. So now I want to shift gears and talk about the COVID-19 vaccines and the demographics of who has been vaccinated in California and here in Sacramento County. But before doing that, I want to look at some of the data that shows how effective the vaccine has been in California. So this slide presents some data about how effective the vaccine has been at the population level here in California. The graph on the left shows daily case rates per 100,000 residents for vaccinated and unvaccinated individuals. And as you can see, rates among vaccinated individuals are much lower, and the rate of increase in cases is much lower as well. The text on the right gives some notable statistics about how effective the vaccine has been here in California. And so some highlights are case rates among unvaccinated Californians are about 600% higher than vaccinated Californians. Of those infected with COVID-19, unvaccinated Californians are 142 times more likely to need hospitalization and 462 times more likely to die once hospitalized. And 1 in 22,400 vaccinated Californians required hospitalization compared to 157 unvaccinated Californians. So we can really see that from a population health standpoint, the vaccine has been really effective at preventing hospitalization and preventing death here in California. Next slide. So now we will look at vaccination demographics in California and in Sacramento County. Next slide. In California, a little over 45 million vaccine doses have been administered. That's about 64% of eligible individuals are fully vaccinated. And on average, about 76,000 doses of vaccine are given on a given day. Next slide. Here in Sacramento County, about 1.6 million doses of the vaccine has been administered, and just under 50% of our eligible residents are fully vaccinated. On average, about 2,872 doses are given in a particular day. Next slide. However, we see significant disparities in our local vaccine uptake. The African American population in Sacramento County is about 156,000, or about 10.5% of our total population. And of that 156,000, about 44,700 individuals are fully vaccinated, which makes up only about 28.7% of the African American population here in Sacramento County. So that's why what we are talking about here today is very important, because we need to think strategically about why the vaccination rate among African Americans in Sacramento County is only 28%. I'm sorry. And we need to identify barriers to vaccination among the African American community. And we also need to develop and implement strategies to increase vaccine uptake among the African American community. And this vaccine influencer training is part of that strategy. So we can have members of our local community spread facts about the vaccine and help to build vaccine confidence in our community. So with that, we'll pause to see if we have any questions, and I'll pass it over to Monica.
Great. Thank you so much, Dr. Owen. So at this time, I'm going to read from our Q&A. If anyone has any questions, feel free to drop those and we will go ahead and move forward with the next portion. At this time, I don't see any questions in our chat. So I don't know if we want to just give it a few moments if anyone wants to add any. And please remember to use the Q&A feature and not the chat box. Okay. So I think we can continue on. I'm not seeing any questions for this portion.
Okay, thank you, Monica. Next, we have Dr. Gates. Dr. Christian Gates is an adult primary care provider for Kaiser Permanente in Elk Grove, and currently co-leads the African American Health Disparities Strategy Team for Kaiser Permanente in South Sacramento. So at this time, I'm going to transition this over to Dr. Gates.
Hey, good afternoon, everyone. Such a pleasure to be with you guys. Definitely excited to dive into a really important topic. And I've had the pleasure of having these conversations not only with members of our community, but also teaching a COVID vaccine class that we had at the beginning part of the year here at Kaiser. And so one of the things that I've learned in having these conversations is that sometimes it's really good to try and anchor the conversation in a comparison. So if you go to that first slide, what we've got here is a question that I get a lot as a physician, which is, Dr. Gates, like, I understand, I see everything on the news, but at the end of the day, is COVID just like the flu? And that's the common question that we get. And one of the things that we know is that COVID is not like the flu. I think that that's a really resounding point that needs to be taken home, because we'll get people all the time who tell us, you know what, I don't get a flu shot and I do just fine. Why should I get the COVID-19 vaccine? And it's really important to understand that COVID-19 is at least 10 times more deadly than the flu. So on average, 0.1% of those who get influenza or the flu will die from the flu, compared to anywhere from 1 to 3.4%. What those statistics actually look like here in Sacramento County when it comes to our African American population is that 1.86% of African Americans as of last Friday who contracted COVID actually died of the disease. What that would translate into is that it would be almost 19 times more deadly than the flu when we compare these statistics. Next slide. And so we talked, Dr. Owen just gave us a kind of a comprehensive illustration of where we stand with the data. And one of the things that he just mentioned was that only 28.69% of the African Americans living in Sacramento County are vaccinated. And I want to put that in perspective. When we were talking about wanting to get to herd immunity, wanting to get to protection levels to where people could be protected from other people's choices, the minimum numbers that are kind of spit out by experts is around 70%. So we're talking less than 30% of our community has been vaccinated. Another way to look at that data is to look at how many of the vaccines that have been given out have been given to African Americans. There's just kind of another way to look at the same data. And when you look at that, what we're finding is that only 7.1% of the vaccines that have been given out in Sacramento County have been given to African Americans. The thing that's so crazy about this is not only is that not equal to the percentage that we make up of the population, but we make up 13% of all COVID cases, but only 7.1% of the vaccinations. So we're seeing just kind of the dire difference between the amount of exposure compared to the amount of protection in our community. Next slide. So just a little bit of housekeeping. I know that a lot of us kind of feel very familiar with COVID at this point, but just to kind of have it listed for completeness, as a reminder, COVID-19 is a contagious respiratory illness. It's a part of a large family of viruses. So coronaviruses are not new, but COVID-19 is. So meaning it would be kind of like years past when we talked about the bird flu or avian flu, it would be a different strain that the human population had never experienced or been exposed to before. Most experts believe that it spreads from person to person, mostly through droplets in the air when someone sneezes, coughs, or talks. Most transmission from COVID-19 is likely from people who show no symptoms. So that's the hard part, is that a lot of times the spread has happened before someone knows to go get tested to try and make sure that they can protect others. COVID-19 affects different people in different ways. There are some people who have very little symptoms. I still have patients in my panel who are months out from being infected, never ended up in the hospital, never needed oxygen, but still are not able to taste, smell, still not able to do their normal functions without fatigue. So there's a wide variety in how this disease manifests. And of course, like I was mentioning, some people have mild symptoms, but it can be as severe as passing away from this illness. So definitely something that we need to be aware of and conscious about. Next slide. So that kind of brings us to today, right? So like we were talking about, COVID itself is something that many of us feel at least somewhat familiar with, but what's been really trending and getting a lot of attention is this Delta variant. Next slide. So the key things about the Delta variant is the Delta variant is more contagious than the other strains. Of course, unvaccinated people remain at high risk. This is what could lead to hyperlocal outbreaks. So if you look at our community, when we have less than 30% of the African American community in Sacramento vaccinated, we're poised to have a hyperlocal outbreak in either our neighborhoods, our churches. This is one of the things that we are talking about when we're talking about risk. There's always more to learn about COVID. I mean, the things that we never know up front is just what this means in the long term, whether or not Delta will have more long haulers, whether or not there will be more people who take longer to recover. Those are the things that we have yet to know about the differences. But one thing that we can say is that we are finding that there are younger people who are getting infected with Delta. I have a lot more patients under 50 who are hospitalized on my panel with Delta. And that's one of the things that we're still understanding is about how the age demographics and the risk change with different strains. But irrespective of the strain that we're talking about, whether or not this is 2020 or 2021, it still remains that vaccination is the best protection against any strain of COVID-19. Next slide. So symptoms of COVID-19, and again, many people might be familiar with this. Common respiratory symptoms end up being the symptoms of COVID. So fever, chills, cough, sore throat, body ache, fatigue. All of those are things that we see with the flu. We see those with COVID. New loss of taste or smell is somewhat unique, not impossible to have with other upper respiratory symptoms, but that tends to be one of the key things as a provider. If a patient is mentioning that, you really are thinking COVID-19 because it's the most unique symptom to happen with a great prevalence with COVID-19 compared to other viral illnesses. We have seen some people who have diarrhea, have more gastrointestinal symptoms like nausea and vomiting, congestion, runny nose that we see with almost all colds. We see that with COVID. The shortness of breath, difficulty breathing, that's the one that people probably have heard the most about with the news. And of course, headache can be a common symptom as well. Next slide. So again, we were mentioning that most people are spreading COVID before they develop symptoms. And there are some people who never develop symptoms. And so being infected with COVID-19 is not something that you will always know for sure about whether or not you've been exposed, whether or not you've been infected. And especially when our children can't be vaccinated, any children under 12 years old, as of right now, where we stand with the available vaccinations, this is a huge risk to our younger population. And so definitely the lack of knowledge, the fact that we could be spreading it to those that we love without knowing it is a really important reason why someone who may not even have health problems may choose to get vaccinated for the protection of others and their family and their loved ones. Next slide. So, you know, a lot of times people feel like, you know what, Dr. Gates, in the beginning of this pandemic, you guys were telling me social distance, wash my hands, wear a mask, you know, stay away from large crowds, large groups, you know, like, can't I just continue to do that? Like, that was good enough in 2020. Why is that not good enough in 2021? And one of the key things I want to really emphasize is just how we are living in a very, very different time in 2021 compared to 2020. Of course, the presence of having a vaccine is a huge difference. Vaccines didn't become widely available until the end of 2020, and that's when healthcare workers were the first ones kind of getting this vaccination. But the biggest thing is the fact that things are no longer shut down, right? So we're no longer living into a society to where we are all avoiding restaurants, avoiding public events, avoiding schools being open. All of those things are now open. And so the reason why they're open is because there has been ample time for people to get protected. So to think that you can have the same level of protection in and of yourself without those community protections leads to a misunderstanding about what really constitutes risk. And so I think that the key thing to take away, especially as those who are going to be having real and honest conversations with other African-American members in the community, is that the safest choice that you can make is to be vaccinated. And that any other protection is really inferior in light of the fact that our communities, our neighborhoods, our jobs, our schools are all now opened up. Next slide. So I will pause here and turn it over to Monica for any questions.
Wonderful. Thank you so much, Dr. Gates. And so I do know that we actually got a few other questions for Dr. Owen. So I may overlap, but again, there will be other opportunities for folks to ask their questions throughout the webinar. So I will just start from the top, and perhaps Dr. Owen and Dr. Gates could answer this. So it looks like, for clarification, was the data of vaccinated COVID, what was the data for vaccinated COVID cases among African Americans?
So we had, and I was mentioning this, that there was two ways that we presented that data. So we have the number of African Americans in our community who are vaccinated. That was what Dr. Owen was mentioning about the 28.69% of our members of African Americans in Sacramento who are vaccinated. And then there's the data that I was presenting on my part that was saying how many of the vaccines that have all been given. So not looking at the community, just looking at the group of those who have been given a vaccine, how many of the vaccines have gone to African Americans, and that percentage was 7.1, even though we make up 13% of the cases. So that was just the comparison, kind of looking, one is looking at who's been vaccinated, the entire African American community. The other is looking at just of those vaccinated, how many of those vaccinated are African American.
Yeah,
Wonderful.
I don't know that I totally understood the question when I saw in the Q&A, but the data that we presented on like the differences between hospitalizations and deaths in vaccinated versus unvaccinated wasn't disaggregated by race and ethnicity. So in terms of like the number of positive cases among vaccinated African Americans, we don't have that data available right now.
Wonderful. Thank you both. So this one is directed towards Dr. Gates. As you mentioned, some of your clients still have a loss of taste and smell. So are there any other long-term side effects that people are experiencing that aren't being discussed?
It's such a good question, you know, and I'll be honest, maybe this is perhaps the most frustrating thing as a primary care doctor, right? So I'm taking care of all the people who aren't in the hospital. And for example, I have a young man who was an avid track runner at his college, who now every time that he runs after contracting COVID gets lightheaded, dizzy, feels like he's going to pass out, right? And so the thing that's so complicated is that there's really no limits. There aren't really rules about what a robust immune response with the long-term effects of COVID can't do. It's literally, we're finding out in real time, what are those limits, right? And so there's not like some preset rules to say, oh, well, the only possibilities for long-term effects are loss of taste and smell. No, I have people who feel like the biggest one is fatigue, that they feel like they just getting out of bed is like they did a huge workout, that they still are having difficulty breathing. Those who have needed oxygen, sometimes they're on oxygen for weeks to months. You know, when I've done these conversations in the past, for young, healthy people, the average amount of time that it takes to get back to their baseline is over a month. And so getting recovered from COVID is not necessarily a quick ordeal. It doesn't necessarily mean that you feel 100% better once your quarantine ends.
Wonderful. Thank you so much. And the last question for this portion is some clarification around the Moderna having a third shot. Can you speak more about this?
Sure, so that's a great question. So the FDA just recently approved, and there are guidelines that have now come through from the CDC for there to be an additional vaccination, a third dose for both Pfizer and Moderna. So the mRNA vaccines have this approval. The Johnson & Johnson vaccine has not been given any approval for additional doses outside of the one dose as of this time. And at this point, only for severe immunocompromised patients. So that would be patients with autoimmune disease, patients with cancer, patients with HIV. And this would be something to where we as physicians have been given very clear guidelines about who would meet that criteria and who would not. And the only reason for the booster, at least at this point, is in order to make sure that those patients get the same level of immunity that someone who's fully healthy would get with 2 doses. So it's like if your immune system is impaired and it doesn't respond to the vaccine, you may not build the antibodies that you would have if you were healthy. And so that's why this data has come through. I'll be honest, I fully expect there to be boosters for probably all of us in the very near future. But as we stand as of today, at this very moment, that's the approval that's come through, is for those who are immunocompromised.
Great. Thank you so much. And I think those are our questions for this portion. So if we want to continue on.
Okay, we're going to go ahead and Dr. Gates, we're going to go ahead and move on to your next slide.
So this part is really kind of diving into some of the questions that you guys are already starting to hit on, which is the available vaccines, their effectiveness, kind of talking about, you know, the differences between Pfizer, Moderna, Johnson & Johnson. So if you go on to that next slide for me. So key things, Pfizer is 2 doses, so both Pfizer and Moderna are 2 doses. The big thing about Pfizer is the one to where people under 18 can get. So if you're talking about any of your kids who may be in high school, junior high, who you're trying to make a decision about the vaccine, this is the only group that has approval is for this Pfizer vaccine. I know that Moderna is working on getting approval. I do not know of any studies with Johnson & Johnson, but I will, if questions come up about that, Dr. Owen is far more the expert when it comes to vaccinations in the pediatric population than myself. If people look at or have family that happen to live overseas, then AstraZeneca, Novavax are vaccinations that are available. I know for sure AstraZeneca is available in Europe. Johnson & Johnson, of course, is the 1-dose vaccine, although I will tell you, this is just something that has been information that we're gathering as physicians, and this is fluid information. But I personally would say that there's probably, if anyone was going to get the vaccine today or tomorrow, I probably would go with Pfizer or Moderna rather than Johnson & Johnson for a few reasons. One, the understanding about what to do, yes or no, in regards to boosters. We're much further along with understanding that with Pfizer and Moderna. Second, we have seen that there has been better effectiveness in preventing illness with Pfizer and Moderna, even though they're all equally good at keeping you out of the hospital. The other thing is that I truly believe that probably before the end of the year, that Johnson & Johnson probably won't be a 1-dose vaccine. They'll probably say that more than 1 dose is needed. And so then that may take away the benefit of Johnson & Johnson. For people who are younger, and particularly women under 50, there were the risk of blood clots with Johnson & Johnson. And as we go through the slides, I'll kind of be able to explain with the differences in how the vaccines work, why there are differences in how Johnson & Johnson works compared to Pfizer and Moderna, because the medical technology between those are actually different. Pfizer and Moderna are the same. Johnson & Johnson uses a different technology. And so we'll explain that, just so if you guys come up to questions with community members and they really want to know the fine kind of medical details about it, I'm going to try and explain it in as simple forms as possible so that you guys feel prepared to do that. Next slide. So all the vaccines are tested, they're safe, and they're effective. So what makes us say that something's safe? What makes us say that something is effective? I think we all pretty much understand about them being tested and about studies being done. Safe, in this context, the key for safety is someone safer getting the vaccine rather than getting COVID? And that's one of the key things. The next question is, are there any serious adverse events that happen because someone chose to get the vaccine? What we are finding is that adverse events are extraordinarily rare. I will not lie, the vaccine will make you sick. You will likely have some symptoms. You may even call out of work for a couple of days. Definitely write work notes for that. I have yet to see anyone have any side effects from the vaccine that are lasting more than a couple of weeks. Truthfully, it's 48 to 72 hours is the vast majority of people. I've yet to have anybody have anything last longer than 2 weeks, and I can count on almost one hand how long that's happened. Meanwhile, I have numbers of patients who are months out from having COVID, like we just mentioned, who have not fully recovered. So there's just no question about the safety of the vaccine when you're comparing it to COVID. And there's also really very little question about safety in general. We've really had very few allergic reactions, although we'll get into that. And it's one of these things that where we continue to monitor. The pause on Johnson & Johnson is an example of the system working. So that pause happened when it was roughly 2 to 3 per million of a rare event of this blood clot. So there weren't hundreds or thousands of people were happening, but it was enough to where there was a correlation that made there have to be a pause for further evaluation. So recognize that this is an ongoing thing, that there is always monitoring, that all of these things are being studied, and that if any patient or any community member that you guys talk to has questions, like that's really what we as physicians are here for, and their primary care doctor should be able to help them navigate that if it's something that is beyond the scope of what we give you guys as tools in this conversation. Next slide. So essentially how Pfizer and Moderna vaccines work. So most of us are familiar with the flu shot. And the flu shot is basically a killed piece of the flu to where your body ends up your body ends up getting exposed through the vaccine. I always tell people that this is kind of like if I were to give you a picture of a house and say, okay, I want you to drive to this house. This is what it looks like. As compared to if I were to give you a copy of the blueprint of the house. So what the mRNA vaccines are really doing is they're really teaching your body the blueprint of the virus. That's the reason why we are finding it still effective, even though it keeps mutating. So what I tell my patients is it's kind of like if that house that you had a picture of, all of a sudden, instead of brick, it has siding. Instead of it being a red house, it's now blue. If it's still 1,500 square feet, 3 bedrooms, 2 bath, you're like, oh, still the same house because the blueprint hasn't changed. And the key thing that is getting your body to recognize as the blueprint is the spike protein. So as you guys see on that picture, kind of what we all have seen, the way that coronavirus looks under the microscope, there are all these spikes that come out of it. That spike is very important to how coronavirus infects and gets into our cells. What the mRNA vaccines do, so just Pfizer, Moderna, we'll explain this with Johnson & Johnson, but Pfizer and Moderna do this directly is they teach your body how to recognize that spike protein. So if it comes into contact with that spike protein, your immune system is already primed and knows to react to stop the infection. Next slide. So Johnson & Johnson actually does the same thing, but it goes through a couple more complicated steps. So instead of just giving your body a piece of the mRNA, which contains no DNA, cannot affect your genetics, cannot get into your cells, will not do any harmful thing, that is literally a blueprint that your body discards of. It does not enter your cells. It doesn't change cells. I always get those questions in the very beginning when this came out. So I think that is super important to say that. But what Johnson & Johnson does is it took instead of doing directly mRNA, mRNA stands for messenger RNA. It is how our body gets the code for proteins. It's almost kind of like if you type in, it's a good example. If you were to do a hashtag, right, by doing something on Twitter, then there's a computer way for where you can link all of those different things with the same hashtag, right? So that becomes linked, through technology. So the link here with mRNA is how to understand and form a protein, which is what your body's recognizing. So it's a little complicated, but this is my bad attempt in trying to simplify it. Johnson & Johnson essentially takes DNA. So you have DNA first, DNA gets translated to mRNA, mRNA gets translated into protein. So Johnson & Johnson did the step before mRNA and took the DNA for the spike protein. And instead of just giving it in the vaccine, it wrapped it in a cold virus that can't replicate. So it's almost, this is not the most scientific way of putting it, but I always picture a neutered virus. So meaning that it can't replicate, it can't duplicate at all. So it's wrapped in another virus. It's DNA instead of mRNA. So it's all these extra steps, but those extra steps made your body respond a lot more directly. So it's like, okay, I see this cold virus. I'm going to react to the cold virus. Okay, now there's also this code for this protein. I'm going to react to this protein. So that's the reason why Johnson & Johnson was able to be effective with just one dose. So we were finding that the efficacy was over 70% with one dose of Johnson & Johnson, whereas only in around 50% with Moderna and Pfizer. To give some comparison, there are some years to where the flu vaccine is only 40% effective. And when we talk about effective, that means that no one got sick at all, right? And so that's why even now, when you have patients who are having these breakthrough infections, a breakthrough infection is actually not failure for the vaccine, not for the key reason why we give it. The key reason why we give a vaccine is to make sure that someone's not dying from that illness. When we went back and showed the slide earlier about only 0.1% of people who get the flu die from the flu, and we're seeing anywhere from 1 to 3.4% die from COVID. Again, that's a key example about the utility and the value of vaccines when it comes to cold and flu symptoms is really not just about keeping people sick or keeping people from getting sick, which is always a goal, but the ultimate goal is to make sure that people don't die from it. So this is a complicated way of saying Johnson & Johnson does what Pfizer and Moderna do. It just goes through these extra steps. Those extra steps were good to make it only one dose, but with the patients that have gone on with COVID, it very likely will no longer be only one dose, although there are no current plans to give boosters for Johnson & Johnson. But the effectiveness is also being called into question, which is why if someone's getting a vaccine tomorrow, I definitely would say Pfizer or Moderna rather than Johnson & Johnson, just based on the evidence that we have right now. Key thing to know, neither one of these has coronavirus, the same way that if I hand you a blueprint, I haven't handed you a house. Right? I just have given you the information about how to build it and how to form the structure. And that's what the vaccines are doing. They're teaching your body how to build the spike protein, just the protein itself, so it recognizes that piece of it. And that's the way that your immune system responds. Oh, next slide. Sorry about that, Kim. So just a quick thing, and I'll be honest, the more that we do these conversations, the less this slide ends up mattering. I will tell you, as a physician who was one of the first to get this vaccine, I keep telling my patients, your doctors were your guinea pigs. Like, you guys are not guinea pigs. It was your doctors who were getting the vaccine in December when we didn't have a lot of information. That's when I wanted to know how many study participants were there, how many people got tested, did they include African Americans in these studies? And this answer is yes, there was 10% African American representation, a minimum of 10% in pretty much all three of the studies. But to be truthful, at this point, we have real life data. Like, we have millions of people who have gotten the vaccine, millions of people who we've studied what their side effects are, millions of people to know that it's safe, millions to see that, we're constantly seeing that 99% of the people in our hospital who are ending up with severe COVID are not vaccinated. So the vaccine data that we got is bearing out in real life. Next slide. So this was just kind of breaking down by race, again, showing that there was 10% African American, a minimum of 10% African American participation in all of the studies. Next slide. So benefits of getting vaccinated. I mean, the key thing is that life and society is opening back up. A vaccine is the only way to engage in our lives, our society, our family, our churches safely. So when you're unvaccinated, I mean, and this is the thing that's interesting, because a lot of this guidance was coming out when we were still talking about the non-Delta strain of the virus, right? So they were saying, like, you could be outdoors without a mask, that you could attend small outdoor gatherings with fully vaccinated family and friends. We've had breakthrough infections. If you're not vaccinated, there shouldn't be anything on the sheet that's green if you're going with where we're at right now with the Delta variant. So I think that's really the key thing, is that there's just not anything that we can really safely do unvaccinated at this point with how infectious the Delta variant is. Next slide. So the key things that are important to just make sure that we underscore is that Pfizer, Moderna, Johnson & Johnson, these are the three options that we have. Again, Pfizer is the only one for children 12 to 17. Johnson and Johnson is not right now being studied for booster vaccines, although we think that that's going to be likely. And so it is the one that's only one shot, but I always want to give a strong caveat when I'm giving conversations at this point and where we're at, that the likelihood that it will remain only one dose is low. So that might start to take away the true benefit of Johnson and Johnson. They all have had very rigorous safety processes. They're highly effective in preventing COVID-19 severe disease. We are seeing breakthrough infections, but that's truthfully expected, especially because I think people need to remember we get a flu vaccine every year because we change the vaccine based on what variant is out and predominant. We're all still dealing with the 2019 version of COVID-19 is the predominant strain of the vaccination, but we're in 2021. So the mutations that have happened is truthfully, truly medically impressive that we're having the level of protection that we are, noting the delay and how many mutations have happened. All three of the vaccines, though, no matter what you choose, so if someone's like, you know what, Dr. Gates, I hear everything that you're saying, I don't want 2 shots. I'm gonna stick with Johnson & Johnson as long as it's still, someone's telling me it's just 1 shot. I would say that's still infinitely better than not getting vaccinated because there's a tremendous amount of evidence that it is strong enough to keep you out of the hospital. And I think that that's kind of the key thing. In regards to how long these will be effective, that's what we're talking about right now, about boosters being likely. And it's important that whatever one that you pick, if you're getting a 2-dose vaccine, so if you start off with Moderna, you have to finish with Moderna. If you start off with Pfizer, you have to finish with Pfizer. There are some differences, even though their technology is the same. Pfizer requires the second dose 3 weeks apart. Moderna requires it 4 weeks apart. There has been no studies that look at mixing the vaccines. So I think that still needs to be super important. Somebody who got Johnson & Johnson, it is not yet FDA approved to go and get one of the other ones. So I think that that's important because that's a question we're getting a lot. That may or may not change as time proceeds, but as of today, if you got Johnson & Johnson, that's it. That's all you need. There's no need to get one of the other ones at this time. Next slide. I think that it's important to really underscore this is the vaccines are free and COVID isn't. It isn't free. There's a tremendous cost to COVID, whether that's the time that's missed in quarantine, whether that's the activities that people can't do, whether that's the loss of income from work, or the amount of time it takes to get back to being productive. There's no charge to the vaccine. And some of the expense of some of the experimental drugs that we try and do, and truthfully, even the ICU stays, it's an astronomical cost to stay in the ICU. And most people with COVID, if you end up needing our help to breathe, that's not usually a short hospital stay. That was the thing that we were finding is people were staying in the hospital for months. And so if people were just making a cost decision, the fact that the COVID vaccine is free is super important to recognize in comparison with the emotional time and financial costs of being infected. Again, we mentioned the ages. We mentioned the fact that there's been millions of people who've been vaccinated, more than 1 billion worldwide. The vaccine is the only way the pandemic is going to end. And I think that that's super important to understand that while we make individual choices, there is a collective consequence to what we choose. Next slide. So Monica, I'll turn it back over to you, see what our questions are.
Thank you again, Dr. Gaze. I have to say that was mind-blowing. I learned so much from these and great information. So I know we're starting to get a lot of questions in the chat. So I'm going to try and keep these to 3 per session, but there will be time towards the end. And some of these overlap a little. So you might hear me kind of give you a 2-part question. So someone wanted to know a little bit more about persuading. I think you answered that quite a bit in the last one, but just any other strategies you wanted to add to that for folks that are reluctant?
Yeah, and we're going to dive into this in some detail for this next part. So I won't spend too much time on it just because I'll steal all of my info from the next part of the talk. But I will tell someone, or I will answer this question kind of as a teaser. And what I've had to learn personally, my mom just got vaccinated. You guys, I have been doing these presentations since January, and my mom just got vaccinated. And I think, I'm a doctor here, but I'm still her child. Let me tell you guys, I have no authority whatsoever when it comes to my mother. And one of the things that I really learned and having to be very humbled in trying to have these honest conversations with her is to really respect the autonomy of the person making the decision. It's really subtle, the difference between empowering and judging. And sometimes it could be the same exact information, but the heart of it has to come from a place that you believe that they are fully capable, extraordinarily intelligent to piece the puzzle together for themselves, and that they didn't need you to do it for them, and that they just need to trust you to make the decision. And I think having to deal with that for my mom, kind of having a flip position than what I have as a physician with my patients, kind of having that power dynamic very, very much flipped, really informed me about how to make that approach in a way that, thank goodness, ended up being effective, and she got vaccinated.
Great, thank you. So next question, can you explain how immunocompromised population is being advised to get the booster? Do they need permission from primary caregivers, or is the public, as public, are they able just to go in and get any COVID information from?
It's a really, really good question. So ideally, they would talk with their provider, because we would want to have, it is nice. I mean, we're able to get the records from wherever you guys go. So we're able to get, if you go to Walgreens, if you go to Walmart, we're able to get it and put it in your medical record. Just because of the nature of usually the complex medical care that someone's having. Again, I would prefer that patient to go through their primary care doctor than a Walgreens, Walmart, whatever's easier, but that allows for us to make sure that, we see directly what they got in the past and what their third dose is being given, that there's no mix up about them getting a booster with the wrong one. That kind of level of surveillance, I think, is important to do. Particularly if people had lost their vaccine cards, things like that, to where they can't show proof, kind of just walking in and just telling a pharmacist, like at a Walgreens. So I would ideally recommend that. That being said, could someone get a booster without talking to us? Yes. And in fact, I think there's over 1 million people in the US who have gotten an additional shot that has not been authorized by the FDA or any physician. So can you do it? I sure enough can't say you can't. There's been more than 1 million people to prove that has been done. But if we were trying to do it in a way that I think is the best in regards to follow-up, in regards to someone else other than that person, the patient themselves, having responsibility about that decision and that choice, and having the responsibility for monitoring, I would definitely want that person to go through their primary care doctor.
Wonderful. And so I guess the reverse to that question would be, is there any data for people that have only had 1 of 2 shots that encourage 2 shots being taken?
Yeah, so I mean, some of this has happened just in real time. So the good thing about the Pfizer and Moderna vaccines is that it's not that they offer no protection with the first dose. It just was infinitely better after the second dose. And some of this is just because of how it got your immune system to respond. And so there are some people who had some benefit, but the likelihood that you're going to be protected from getting COVID at all is extraordinarily low. So breakthrough infection, if somebody didn't complete the vaccine, like we kind of expect it. We kind of expect that person to still get COVID. Maybe that they do better and don't end up in the hospital. Again, I think that it's important to understand that anything in medicine, there's nothing that's 100%. So even though like we're talking about 99% of people in the hospital are unvaccinated, if someone didn't complete that vaccine series, I would expect them to be at risk to be in that 1% who got exposed to a vaccine but not fully vaccinated and thus not having that full protection.
Great. Thank you. Was that 3 questions already? Okay. So let's see, maybe I'll add a little piece here because I think it kind of meshes with that. So I'll finish here where someone's asking when you're looking at the risk of blood clots with the Pfizer and Moderna. So for a person with a history of those, can they safely receive those vaccines?
Yeah, so the blood clot risk, and it's really crazy. I mean, like medically, we're talking about blood clots in the sinus cavernous thrombosis. So it's this really specific type of blood clot. So it's not your common pulmonary embolism, deep vein thrombosis. It's a very specific type, but that was seen predominantly in women under 50, and only with the Johnson & Johnson vaccine. So if someone had a risk for blood clots, then definitely getting Pfizer or Moderna would be the ones I would recommend.
Wonderful. All right. I think I will let you continue. Thank you so much.
And so we can jump to the next slide. And what I'll do, because I really feel like people will have a lot of questions, and I will want to make sure that the community leaders feel equipped to answer those questions and be able to ask both myself and Dr. Owen any questions that they have. I'm going to go through this more quickly so that we have that time to dedicate for you guys. So, and how to effectively communicate about COVID-19 vaccines. If you go to that next slide, one of the key things that I think is important is looking at some top reasons why people are not getting vaccinated in the community. And we're going to kind of fly through these, because if these don't apply to you guys, then it won't be as helpful. But knowing what to do is going to be important. So the top 5 reasons here, if we go into the next slide, and I'm just going to mention them all and then talk about them at the end. So the beliefs that the vaccines were not tested enough, were created too quickly, people worried about side effects about the vaccine, worried that they could get COVID from the vaccine. There have been people who have worried about infertility or problems with pregnancy or breastfeeding, and they're worried about the ingredients in the vaccine. Next slide. I do want to just quickly mention that when we're talking about as African-American community leaders, that there is also a unique history that creates unique concerns. And so 1972, the Washington Star had a front page that said germ warfare declared on Blacks, and when they were breaking the Tuskegee syphilis experiment. And there's been a large segment of the population that believe that the men in the Tuskegee syphilis study were given syphilis rather than simply prevented from being treated for syphilis. And so that actually has been one of the things that that I've had to work through with even some patients here at Kaiser, where the concern was, could the government give us something, give us an illness? And I think that it's important to understand where the roots of that question and that concern come from. And some of it goes back to the 1970s and it being misrepresented what actually happened to the men in that study. It was egregious and it was horrific. that prevention of treatment was withheld for decades, but the men were not given syphilis itself. That's not something that people need to worry about in getting COVID itself from the vaccine. So just because of the history of Tuskegee, just important to understand where people are coming from and why people might have that belief. Next slide. So we'll skip through these because I'll explain them in a paragraph rather than in slides. So we talked about vaccines being created too quickly. We'll go into detail about that. You can skip to the next slide. And then just go ahead. We'll keep skipping here because I'll just go over all the points together. Next slide. The only thing that I will hang on is this one, because this has been really, really helpful for me in talking with patients. And so I do want to spend a little bit of time making sure that everyone gets this particular information. I compared getting the COVID-19 vaccine to running a marathon. So can you physically run? Pretty much anyone who's able-bodied can physically run. Can you roll out of bed and run the Boston Marathon? The answer is no. You're going to hurt yourself if you don't train before you run the Boston Marathon. And the same is true with your immune system. If your immune system isn't ready to handle the vaccine, like if we're having something that, at least with the alpha strain, was anywhere between 94 and 95% effective, it's doing a really good job at it, triggering your immune system to respond. There are things that you need to do to prepare for that. And if you do these steps, I've seen, I give this class and I've given this to my patient, and I've given every single one of my family members this, including my mother, who had no side effects to the vaccine, but they finally listened to me and they did follow these steps in detail. So you want to sleep at least 7 hours the night before the vaccine. I usually say for these things and if you guys want to screenshot it, I usually give it as a handout when I'm talking to patients. So, I usually say to do these things the day before, the day of, and the day after for making sure that your immune system's ready to handle the vaccine. Sleeping at least 7 hours, staying away from sugar. Sugar weakens the immune system. So the same way that sugar sticks to the red blood cells is how we tested in diabetics. It sticks to the white blood cells that fight infection. Vitamin D is important. There are a lot of studies that show decreased vitamin D impacting the immune system. And so increasing outdoor sun exposure or taking vitamin D supplements, that's the one thing that's unique. I don't necessarily recommend vitamin D for just cold and flu, but for COVID, there's a lot of correlation that, especially for our population, when we tend to be vitamin D deficient, that's super important to understand. Taking vitamin C, super beneficial. The biggest mistake people make is that they'll try and get their vitamin C from like orange juice. There's a ton of sugar in orange juice. So you really want your vitamin C to come from like hot lemon water is my personal favorite because there's no sugar in that. It's not a fruit that's naturally sweet. But if you were going to go with something that was a fruit, eating an orange itself, much better than drinking orange juice. Taking zinc echinacea, something like Airborne will have vitamin C, zinc echinacea. These are supplements that have been clinically proven to help with the immune system and fighting. And so having that on board, making sure that you're really conscious about your health before you take the vaccine has been very anecdotal, kind of going with my own patients, my own family. I've yet to have anyone have severe reactions to the vaccine or severe side effects following this. I mean, to be truthful, when I took the vaccine in December, I didn't prepare. I didn't think it was going to be a big deal. I thought it was going to be like the flu shot. And I literally almost called out of work the next day. And for people who don't know me, I have an award for perfect attendance. But that next day happened to be Christmas Eve. And I was like, I'm not going out like that. I can't call out Christmas Eve. Like, that just looks horrible. So I prepared for the second dose. And usually you have worse side effects with the second dose rather than the first. And I had no significant symptoms whatsoever, actually preparing and understanding what I was getting my body into. So that was what made me have that insight, which is my own personal experience. And then taking the information that I know about preparing the immune system. So this is a good way to have something to tell people when they're like, I just don't want to be sick. And I hear that people got sick after the vaccine. It's explaining This vaccine is like running a marathon. If you don't prepare, you're going to hurt yourself. Make sure to prepare, and these are the ways to do it. We can go to the next slide. So afraid of getting COVID from the vaccine, we talked about it before. There is no live virus in this vaccine. There's no way to get COVID from the vaccine itself. Next slide. So vaccine and fertility, you can skip to this one because I'll tie that with the pregnancy and breastfeeding. So we can skip to that next slide. And then I think there might be one after that. You can go to the next slide. Okay, oh, the harmful ingredients is next. Okay, so quickly, let's talk about the vaccine being made too quickly and then the issues about pregnancy. So the vaccine being made too quickly, super important to recognize that the foundational blocks about the vaccine were in development for over a decade. And so this would literally be like if you were already building a building and then all of a sudden you realize that you needed to have an office building by tomorrow, and that you just adjusted it to make sure that it had the features for an office, but you had already bought the land, had already laid the foundation, had already purchased all the materials. So like, did you do it fast? Yes, but did you do it from scratch, from zero to the completed project in the amount of time given? The answer is no. And so I always use the example of the extreme house shows that build a house in a week. It's like, if you have money, the resources, in this case, the resources is not just financial, it's the fact that science has been working on mRNA vaccines for over a decade before this problem presented it to where they apply that medical knowledge to it. So when someone asks you how long did it take to create the COVID-19 vaccines, the answer is not 1 year. The answer is over 10 years. That's true. That's the true medical answer. In regards to people being concerned about pregnancy and breastfeeding and childbirth, how that myth got started is that there is a gene in the placenta that's similar to the code for the spike protein. And the example is kind of like if you were comparing phone numbers, if two phone numbers had one number that was the same. You're not going to accidentally call the wrong number if only one of the numbers is the same. And so the other thing that's really the proof against this, to be truly transparent, is that there were over 30 women in the trials who got pregnant in the middle of the trial. So the whole idea is you never want to do a test against pregnant women when it's experimental. It's just medically is not something that we do. You almost never do a study in women who are pregnant. But there were women who accidentally got pregnant in the middle of this study. So, I mean, you kind of had from the very beginning evidence that this is not affecting fertility, because there were women who were accidentally getting pregnant who were a part of the studies, which is how we knew that there was some safety in pregnancy, because those women still continue to be a part of the study and still were monitored. But the bigger point is that there are women who have had stillbirths. There are women, pregnant women who have passed away due to complications of COVID. The risks for COVID are infinitely higher. And more importantly, the same way that we try and tell moms to take all these health steps before getting pregnant, getting the COVID vaccine is no different. It's strongly recommended. I have several friends who were pregnant and in their later stage of pregnancy, since, you know, I'm 36 years old. So I have an 18-month-old at home. So I'm in the group of physicians who are just now starting to have our families. So I have several of my friends who are physicians who got COVID vaccine while they were pregnant. And it's been proven to be safe and has been studied. And so, but getting COVID-19 while pregnant can be life-threatening to the mom and the infant. So that's super important. In regards to the harmful ingredients in the COVID-19 vaccine, people being concerned about that. So we've covered multiple times, there's no live virus, there's no COVID in the COVID-19 vaccine. Another thing that people sometimes ask, because it's in other vaccines, there's no latex in this vaccine, there's no egg in this vaccine, there's no iodine. So if people have those common allergies, super important to know those aren't ingredients in the vaccine. The vaccine is safe for those who are immunocompromised. So we're already talking that the issue is not getting the vaccine itself. The issue is whether or not you need an extra dose. Like that's the issue. Like it's definitely safe for those who are immunocompromised. They actually need more doses than us. And then finally, let's talk about this microchip thing, just because people bring it up. Because that was the reality, and the humility is that usually every lie has a kernel of truth. So I was like, where in the world did the microchip thing come from? So it turns out Columbia University is studying how to do implantable microchips to basically replace medical devices. So basically, instead of having a whole surgery for a pacemaker, we just give you a shot. It has this tiny little microchip size of a grain of sand, and then we don't have to do this whole surgery. They are so early in this development. Like they are just injecting these things into chicken breasts. They have no idea whether or not they can do anything. It has not been developed for the purposes of control. There are no microchips in the vaccine itself. But just in case somebody wants to tell you that they've heard about this is where this is coming from. Very, very early stages, not yet even being tested on patients. But people got a hold of the fact that this technology existed, and they connected it with the COVID-19 vaccine to come up with a conspiracy. And that's how all of that got started. But there are no harmful ingredients. The allergic people who have had anaphylactic reactions, meaning that they stopped breathing or needed an EpiPen after getting another injection, those patients, you really want them to get their injections at their doctor's office rather than your CVS, Walgreens, Walmart, so that we can do the monitoring, because the monitoring is supposed to be 30 minutes, I believe, for those who have any history of severe allergy. But we really, I'll be truthful, there's no allergy test. We get this question a lot. Like, okay, so the ingredients in the COVID-19 vaccine, which is polyethylene glycol, is the ingredient that people talk about having an allergy to. They're actually, that is a collection of things. It almost would be like telling you that you're allergic to trail mix. And you're like, okay, well, that's not one thing, right? Polyethylene glycol is not one thing, and there is no skin testing for it. It would be exceptionally rare that anyone would knowingly have that as an allergy. Probably would have had a medical paper written up for them if they truly had that isolated and understood. So there really are not anyone who would have a known allergy to where we would say you can't get the COVID-19 vaccine. We do tell people that if they had a severe reaction to the first dose, that they can't get the second dose. But the key thing would be that if they had a severe allergy to any other vaccine in the past, the key is not that they can't get this vaccine, that they just need to get it in a healthcare setting where they can be monitored. So that's the key thing about that. Next slide. Okay, so we got through that in 15 minutes, so I would have time for this. This is the important part, is how do we have those conversations? Next slide. So there are kind of three key points that I won't even say that I've learned. I think it's more humble to say that I'm still learning when I'm having these conversations with my patients. And one is to ask and listen to the answer. Asking people what they think about the vaccine, asking them about their concerns, because that really starts to guide the conversation. The next is to find some common ground. Sometimes people are not worried about themselves when it comes to illness. There are some patients who are not worried about dying from the disease. And even though that's rarer, that is definitely true. There are some people to whom you're like, you could die from this disease, and they're like, that doesn't concern me. I'd rather take that risk. But they may have someone in their life who they are concerned about protecting. And I think that it's important that even though this is an individual choice, it's not an individual choice that has individual consequences. It has most of the people who we see infected. If mom's infected, then that means often that dad and all the kids are infected as well. So it's households who get sick. not individuals. And I think that that's super important. So sometimes finding the common ground is not about the health of the person you're talking to, but maybe they may be more worried about their family or their children. And then sometimes it's just about the things that they feel at risk doing. You know, people who are not getting the vaccine, particularly in our community. So I know a lot of African-American patients who have told me, I'm just not going to go out. I'm going to stay in until the vaccine or till the pandemic is over. And there's really just no timeline for that in the horizon. And so recognizing that all of those interactions are things that can be given up. And sometimes that is a good common ground to reach people with. And like I mentioned earlier in answering the question, just recognize that our ultimate goal is to empower rather than convince. I think that really telling people that we trust them to make the safest choice for them and their family, and then giving them the information to do so, allows them to step away and make their own decision without having to tell us to our face or just hypothetically to the medical community that we were right and they were wrong in their stance, right? So sometimes people want the space and the grace to change their mind without having to acknowledge that they needed to change their mind because they now feel like what they were thinking before was incorrect. Ironically, sometimes that's two very different things. Seeing that something else is right and admitting that you're wrong, if you tie it to where somebody has to admit that they're wrong in order to move through with making a personal change, I think that's just creating a barrier. So just giving them that space to empower them to make that decision, even giving it to where they don't need to tell you what their choice is going to be right then and there. I think all of those are super important in initiating the conversation. Next slide. So 5 key messages, getting into how do we do this. Next slide. So if you guys were to have no other takeaway points, I would say that these 5 key messages are probably the most important in regards to this conversation. Number 1 is that the vaccine is safer than COVID-19. The evidence is overwhelming that the vaccine can protect you from dying from COVID-19. We're seeing it in our hospitals. We did a report here at Kaiser just this afternoon. Overwhelmingly, the patients who are hospitalized and in our ICU units are unvaccinated. And so getting the vaccine is the best thing that someone can do to protect their life and their health and their family, and is infinitely safer than COVID. And I would emphasize that we really only have 2 choices. Patients can either choose to take their chances with COVID or to trust the vaccine. But we really, with how widespread this is, there's not really an option to make it through 2021 the way many people made it through 2020. Going to what we mentioned earlier, the side effects from the vaccine are common, but they're temporary. So like we mentioned, I have people who have most side effects are lasting between 48, 72 hours, but the health impact from COVID-19 infection can last for months, even if you're never hospitalized, like we were talking about earlier. Again, 2021 is not 2020. This virus will continue to mutate. Delta is not the last mutation. And what the virus is mutating to do is to figure out how to get an infection that kind of circumvents all of our efforts against it. But to be truthful, if we were looking at what we've been doing in large as a country, as a global community, we have been helping the virus, not helping ourselves, right? Arguing about masks, not social distancing, not getting vaccinated. All of the tools that have been given often have been this debate. And what this has done is just given the vaccine time, giving the vaccine time to mutate and become something that we're more and more challenged to deal with. And this is something else that's a little bit on a personal note. In 2020, you had this kind of galvanizing cry in medicine about wanting to come to the aid of a natural disaster. Many of us who've entered into this profession did so with the goal of helping people. And for many, we felt like, okay, this is our moment. This is what history is asking us to do. We are going to step up to this challenge. At this particular point in time, you have a far less number of doctors who have survived that challenge from a professional level. So there are not the same number of doctors who work in the ICU. There are definitely not the same number of nurses. There are nurses who are saying that there is no amount of money that you can pay them to continue to do this work, because to our core, it is disheartening to see people die when it seemed like we had another option. And to be the only one at the bedside holding their hand, to have to be family for these people. And for many people who work in these environments, they couldn't do it anymore. So when people get sick, you're not having the same level of care. There's just not the number of people there. And so I think really underscoring, especially before we hit cold and flu season, like for sure, you guys, like the system is wearing thin to where what you expect when you walk through the doors of the emergency room is not going to be what it was in 2019 and even 2020. Next slide. We talked about the vaccine wasn't created in a year. We emphasized that. If anyone asks you how long did it take for the vaccine to be created, remember the answer is over 10 years. And we talked about that in detail. And like I was just mentioning earlier, that recognizing that there are really only two choices. Someone may feel like they are choosing to try and stay safe without getting the vaccine. And unfortunately, that choice does not exist. I tell my patients and I look them in their eye that if they choose not to get the vaccine, then they will likely get COVID before the end of the year. And as long as they understand that, and that that's the choice that they recognize that they are making, then I know that I've informed them to the point of educating them about the fact that there's not another alternative to stay safe without the vaccine. I think it's important to also recognize just big picture. Even when we're not in the pandemic, we will still have COVID-19. Much like we still have the flu after the flu pandemic of 1918 ended. Ultimately, the choice does belong to the individual, but they need to recognize how many things are linked and tied to that choice. And we have a ton of information on this presentation that you guys can give to try and equip your conversations with your community members. Next slide. So just in summary, acknowledging the personal choice, but we talked about how things are tied to that choice. Keeping lines of communication open. My mom didn't make the decision in a day. It was not a one-time conversation. Don't get defeated if you feel like you haven't moved the needle. Sometimes people just need to have that time to process. And that's why I'm saying empower rather than trying to convince. Convince makes you feel like you have to have a decision by the time you're done talking. Empowering is giving someone the information that they need and trusting them to make the right choice. So just recognize that you're making a difference, even if you don't see it right then and there. And then the vaccine is so easy to find. Monica knows when we were doing these conversations before, we were talking about pop-up centers and sites. I mean, like, you guys, we have so many vaccines right now. You do not need an appointment. You can walk in and tell us which one you want. Like, that is where we are at. So the supply is far exceeding the demand. Getting a vaccine right now is extraordinarily easy. There's never been a better time to do it, and we need to do it before cold and flu season hits. Next slide. It's okay to say that you don't know. I mean, there's still things that as a physician, I don't know. I don't know how long symptoms will last. I don't know whether or not we'll need boosters. I don't know whether or not we'll need it every year, the same way we need the flu vaccine. But saying that I don't know is a way to build trust. It allows your community members to know that you're not going to tell them something that you don't fully understand or the information isn't there yet. Next slide. And so finally, in conclusion, still saving some time here for some questions. The vaccine offers hope. It's the only way to end the pandemic. And in countries with high vaccination rates, thankfully, even in California, having higher vaccination rates than some of the South, we see less hospitalizations. But because we have less staff across the country who now work in healthcare, even in California, we're having the effects of this pandemic impact us in a way that, you know, we just aren't well prepared to handle. And so we're seeing less hospitalizations, but if you can handle less hospitalizations, even having less hospitalizations than other areas is not anything to think is safety for those who don't have the vaccine. Getting the vaccination is the best way to protect your loved ones, especially children who can't get vaccinated yet. This has to be a community choice. We're not going to protect the most vulnerable among us, especially kids who are going back to school, without getting the rates down in our community. We respect and empower those who are making this choice, and hopefully today helps you guys feel like you can help them make that informed decision. Next slide. And with that, I'll turn it back over to Monica.
All right. Thank you so much, Dr. Gates. We got quite a few questions in the chat, and so I'm going to just jump right in. Some of these I would also like to direct towards Dr. Owen. So for this one, anyone could answer this one, but a few people are wanting to know, how long should someone wait to get the vaccine after they've had COVID?
So Dr. Owen, go ahead, take that one.
Yeah. So at the beginning stages, it was 3 months, but I think that was mostly for vaccine availability. It kind of depends on, to some extent, the severity and whether you were hospitalized and what kind of treatments that you may have had. But if you had like a pretty standard case, you didn't require any hospitalizations or any like a therapy that may affect your immune system, then the recommendation now can be like up to 2 to 4 weeks after you have recovered or after you were diagnosed with COVID, that you can go ahead and get the vaccine.
Great. And this one is also for you, Dr. Owen. So are there any key comparative experiences or lessons among groups of people that are of African descent or Caribbean populations, just to really amplify and educate? Sorry, if that makes sense.
Yeah, I'm not sure I'm totally understanding the question, sorry.
So looking at people of African descent, are there any things that you would recommend to amplify or to educate? Are there any differences in terms of, you know, different cultures within the Black community? That's how I interpret this question.
Yeah, I think there oftentimes can be many differences, and I think it often kind of can come down to, at least from my perspective as a pediatrician, caring for people from a lot of different cultures, is kind of what their trust in. What is their trust level in the healthcare system? What is their trust level in their healthcare provider? And I think like acknowledging from different cultures that, you know, the healthcare system itself hasn't always treated people from diverse backgrounds very well. And there's lots of reasons where people may have some distress. So for me, I think it's always important, you know, regardless of kind of what the background is, to really kind of understand if there's any distrust in the vaccine, what that is rooted in, and to kind of acknowledge that there, like Dr. Gates said many times, there's often kind of some truth into some of these concerns or a valid reason for them. So just really trying to understand kind of where those concerns coming from and get to the root of the issue, I find is very helpful.
Great, wonderful. And so another question here, kind of jumping into the youth sector, have there been studies on newborns from mothers who have taken the vaccine while being pregnant?
I think there's a lot of studies that have looked at kind of tracked the pregnant women who got vaccines over gestation. So pregnant women who get vaccines now, they can kind of they can basically enroll in an ongoing study. So it looks at, I think it's up to like 140 something thousand or more people who have kind of signed up for having gotten the vaccine while they were pregnant. And there's definitely been lots that have looked at the risk of like early delivery and premature delivery when pregnant women get the vaccine, have gotten the vaccine. So far, the data has showed that the vaccine is very safe. I'm not specifically sure if how much they're looking at specifically for the newborns, but there hasn't been any alarming kind of outcomes in the data that has looked at pregnant women and vaccines thus far.
And Dr. Gates, did you want to add to that?
The only thing I was going to add was kind of the same thought process, is that pregnant women will get the tetanus vaccine every pregnancy, no matter how long it's been. The whole idea is the fact that the antibodies from the mom can be transmitted to the kid to offer some protection, in particular before they're old enough to get vaccinated. So the flu vaccine is probably the best one-to-one comparison. Why we recommend the flu vaccine so strongly in pregnancy is for the hope that some of the antibodies would be transferred to the baby in utero. And so there is a lot that a pregnant mom can do getting vaccinated to not just protect herself, but also have some potential for transfer of antibodies to her child as a means of protection as well.
Great, thank you. And I'm gonna condense two questions into one. So looking at kids returning back to school, there are a few questions about when younger children will have the option to be vaccinated. And just the two of you, what are your opinions, in youth mandate and schools mandating youth to be vaccinated if they're under 12 years old, when those vaccines are available?
Yeah, so the studies are underway, and everything that we've seen so far suggests that we anticipate that at least for 5 to 11-year-olds that the vaccine will be available to them sometime between, sometimes this fall or this winter. The results so far are very promising, and I think that they're looking just to make sure that there's no longer term consequences. And in vaccines, typically, if there's reactions, they're going to be in the immediate or recent period and not as far out. As far as a vaccine mandate when it comes, I think that can be a very political question, and it would be a long process if it ever got to that point. I certainly don't think for ages 5 to 11 that we will see that, because we haven't seen it. There's not a mandate for vaccination for children who are able to get the vaccine now. So I think that's more of a political priority question that may happen much farther down the line when the vaccines get FDA approval for that age group. But I don't anticipate that it would be something that we would see in this upcoming school year.
Great, thank you. So I think for this next section, we are going to give everybody here a 5-minute break just to kind of get up, stretch, refill teacups. And I wanted to remind everyone that as a courtesy for staying with us this day, we are giving everyone a free t-shirt. And I'd like you to complete the link that's in the chat box with just some information to input t-shirt size and give us an idea of who joined us today. And then we can all reconvene. On my clock, it shows that there'll be 3:40. So we'll just give everyone a 5-minute break and we'll come back and finish the rest. Thank you. Hey, welcome back, everyone. I know we have some additional questions. Just with the break, did I miss anything, Dr. Owens or Dr. Gates, that you wanted to address? Okay, so we will go ahead and continue on. And as a reminder, please complete the Google link that was dropped in the chat with your feedback to help us know who's joined us for today. So let's see, we've got a few questions here. So one of the questions that was asked is, why is it that people that are being vaccinated, people that have had the vaccine are being asked to wear their masks when indoors? Are they still risking the public of transmitting the disease? What would be the reasoning behind that?
So I think the thing is particularly with the Delta variant and kind of how we were mentioning, we're seeing breakthrough infections. They're minimal, but for example, we've had groups where everyone has been vaccinated to where there still has been people who've come down with COVID in group settings. So we still recommend people who are vaccinated, if they're having symptoms, to get tested. And I think it's just an acknowledgement that the vaccine is not 100% effective in keeping people from getting COVID at all. If anyone's a sports fan, you know, Chris Paul was out during the NBA finals because he had COVID, even though he's vaccinated. Like, this is the world I live in when I'm not wearing this coat, is definitely watching a lot of sports with my husband. Like, you'll hear this often, right? That people who are frequently tested, living in kind of these bubbles that you see in breakthrough infections, but we're seeing it in our community. And so the hardest thing is the fact that, especially with Delta being so easy to transmit, I don't think that we can quantify. Before, we would say a high risk exposure is more than 30 minutes with both people unmasked, less than 6 feet apart. Well, that was for the Alpha strain. Delta is more transmissible. And so even with those who are vaccinated, I think that there's two things. There's individual health and then there's public health. And the public health part of it wants to keep spread at a minimum.
Great. Okay, next question. So a fear in the African American community is that the government is trying to control you and that they're doing it by the vaccine. You know, some workplaces are actually mandating vaccines. Some folks feel like COVID trackers might be on their cell phones. So how do we really address the conspiracy that these fears, you know, bring about in the community? Dr. Gates, I know you answered that a little bit, but these are kind of new subjects. So any feedback around that?
Dr. Owen, I'm going to let you take this one to see if you got a new perspective to offer us.
Well, I think you did a great job, but I think it's just really important to realize that, you know, sometimes to some people that these things may seem silly at times, but there's lots of historical evidence of government mistreatment of Black people in this country, and that's in the healthcare system, and that's outside the healthcare system. And I think we can't evaluate people's thought processes or decision making without really thinking about the history of Black people in the country. So for me, I think concerns are valid. It's valid to distrust what the government may want to do and think about. But also, I think one of the big things that has changed and is changing is representation, right? So for the first time, probably, or more so than in the past for sure, Black people were definitely involved in developing the vaccine. As Dr. Gates pointed out, Black people were involved in the studies at higher levels than they have been historically. So I think number one is it's really important to acknowledge where those concerns come from, but also to recognize that Black people and advocates had more of a role to play in the development of the vaccine, more of a role to play in how it's communicated to the community, more of a role to play in the studying of it. And I think it's important for other Black people to, you know, just kind of talk to people around us and understand what their concerns are, tell them our experiences with the shot, like Dr. Gates said, when I got the shot, I didn't feel great for a couple of days. And I tell people when we're talking about the shot that they can expect that and what that means. So for me, it's just a matter of like recognizing people's experiences and their thoughts and being honest about the information that I have or that we have, and trying to present it in a way that is respectful of their mindset and thought process.
Great. And keeping along the same topic, looking at some of the HBCUs like Howard University and Meharry Medical College, can you talk about the fact that some of those original trials were done at those institutions, especially for Pfizer and Moderna?
Yeah, so I know for sure about Meharry's role in this, being an historically Black medical institution and school of medicine, kind of being on the ground and some of the pioneers and having their patients as test patients in the trials. When we talk about it, we talk about the fact that, and some of this is how the conversation evolves, right? So often in the very beginning, people wanted to know, can we trust the results? Like, did they test it in people who look like us? And I think now people want to know, what is the experience of somebody who I know? And so this is where, like, if you're coming to someone like Dr. Owen was just saying, I truthfully feel like at this point in the conversation, your personal story is probably going to have more weight than any of the history of what went into the development. The moment my mom got vaccinated, I found out my brother and sister weren't, and they got vaccinated the next day. And I was like, I should have been talking to y'all. But like the moment my mom got it, look, they didn't need no study. They didn't need to talk to anybody. That was all they needed to know, was somebody who they trusted. And particularly, I think that there is something that is extraordinarily powerful about if someone loves you, right? And so love is a very powerful builder of trust. And I think that having a genuine concern, I think that if you're talking about bridging the gap between, sometimes I'll tell like high school students who I was mentoring that sometimes we'll see the negative effects. The negative effects in our society is often where love has been absent. And what Dr. Owen is pointing out about our history is a group of people to where love has been absent in regards to how our government has overseen certain things. Dr. Owen and I both graduated from Xavier in New Orleans. We both were college students during the time of Katrina. We can tell you about what the lived experience is about being a part of a community that has learned to have a personal reason to mistrust the government and their care and protection. But where you don't mistrust is people who've proven that they love you. And so I think that this really, to be truthful, is going to take just being honest and truthful with each other, but also having the people who do care about people. I do think that this is going to be more family motivated than it is going to be from a physician, and maybe even from anyone who doesn't kind of have that personal relationship. But what we can do is kind of educate families and let that kind of information spread, and then be really honest and open about our personal experience, so that honesty lets people know that we're not trying to convince them for any ulterior motive.
Great. Thank you. So this question is asking, so for the people that aren't concerned about the potentially fatal side effects from COVID, are they basically saying that they are comfortable living with the long-term effects instead?
I'm going to give my 2-cent soapbox and then let Dr. Owen dive in. But the hardest thing that I can't reconcile is if you would still go to the ER if you have effects to where you can't breathe, right? So meaning like, if you would want medical treatment, if you had severe effects of COVID, you're trusting the same people, right? So it's not a different group of people who are telling you, like about how to prevent being ill, that you're trusting to treat you once you get sick. And there's less and less of the ability to do that. And so I haven't met as many people who would be willing to look me in the eye and say, Dr. Gates, I would rather get COVID than get the vaccine. And if I get sick, I won't come see you. Is that last part? It's the last part. The last part they won't say, right? And so I think that if someone was really like, I'm trusting my immune system, there's a disconnect if there's that limit and we know what the risks are. So, I think that's the honest thing is to really get people to quantify to what point. Because there are plenty of people who didn't want an experimental vaccine who will take experimental drugs when they can't breathe. And so I think that there needs to be just this honesty about taking action before it becomes an emergency.
Very well said.
Yeah, and I think there's a lot of different things in that question. I think first I would just go back to, it can be frustrating, I think, especially as like the medical profession, public health system becomes overwhelmed with cases and, fourth, fifth, however many waves. But really with each individual to try to take time to understand what they're saying when they say whatever they say about a COVID vaccine. So sometimes we don't take the time to like clearly listen and have them articulate their thought process, and we get kind of frustrated. And so I think it's important to try to engage where we can. And then two, I think if we think about the evolution of the data, so at the beginning, of the vaccine, there was a lot of talk about how it was pretty serious for elderly people, but for younger people that it really didn't have that much of an impact on them. And if you're not paying close attention, you may hear that and say, oh, you know what? If I get COVID, it won't be the worst thing in the world. What's the likelihood that I get COVID and the likelihood that I get seriously ill and the likelihood that I die? Those three things in combination are pretty low. So I'm going to make the best decision, I think, for me at the time. I think what's difficult about it is, though, that the data changes. And that's just the nature of any health condition. And now we're seeing more young people get sick, more young people are dying. If you look right now, there's more kids hospitalized for COVID-19 this week than there has been at any point in the pandemic. There's more young people being hospitalized. So I think the nature of what we're seeing is changing, especially as many senior citizens get vaccinated. And people have COVID fatigue, so they may not be paying as close as much of attention as they were at the beginning. So I think it's really important for us to continue the outreach and continue to outreach specifically to people who may not be well informed on certain parts of the data, or where people we know who are less likely to get vaccinated, and let them know, hey, things are a little bit different than they were 6 months ago, 12 months ago, and they'll be different in 3 months and 6 months. And I think we have to continue to update our communities on, what we're seeing in the public health and healthcare system, how that changes their risk, and helping them to make informed decisions.
Okay. So keeping on that same subject, there's a question here about the Delta variant when we're looking at, a blend of vaccine changes. Do you think if there is a need for a booster, that the actual components or ingredients in that vaccine will need to be changed or upgraded?
So it does look very clear that, as soon as potentially in September, that we'll be recommending boosters, at least from Moderna and Pfizer. And at this point in time, those boosters will not need to change. What will happen, years down the line, it's difficult to say. It's certainly possible that in the far future that there could be a variation and there may need to be changing of the vaccine. We're not there yet, but as Dr. Gates pointed out, the flu shot is slightly different annually and tries to protect us against the strain that's coming. So for the upcoming boosters, it's not something that we'll see, but it's hard to predict how COVID will play out. it kind of depends on how many people get vaccinated and if we can get the spread under control long term.
And I think just to give people a comparison, when we give a booster for tetanus, whooping cough, the Tdap, we don't change it, right? Like it's not a different vaccine. It's just a true booster of the same one. And I think because the mRNA technology is about the blueprint rather than the picture, then the thought is, will we see a more robust response? And again, some of the boosters are looking at people who got the vaccine in the very beginning. It's going to be a time thing in regards to that, much like we see with tetanus, where people get it every 10 years. So I do think that that's one of the things that we're actively trying to figure out, right? So the whole thought and why mRNA vaccines were in development for so long was because you were moving beyond doing a killed virus so that you wouldn't need to do as many different versions to have protection. So I think that that's part of the reason why this is coming into thought process about giving an additional dose of the same medication.
Great. All right. So this is going to be our final question. And again, kind of in the same theme, for some folks wondering about how folks were getting sick after the first dose or the second, would you say there's something that makes someone get sick after the first one, or what are the chances that you're going to have a reaction of those two?
So the chances of having a reaction are pretty high. I would say I try not to tell people that I got sick. I didn't feel well, but for me, I think it's not like very scientific, but the way I like to think about it is the whole point of an immunization is to prepare your immune system to respond when it sees that virus entering your body, right? So any immunization is really just a primer for your immune system to begin to operate, right? So kind of what you're just seeing is your immune system kind of flaring up and doing what we're asking it to do and prepare to protect you from the vaccine. So that could be a fever, it could be a headache, it could be muscle aches. It's pretty standard. A lot of people will get it, but it's not COVID. And it's not necessarily feel great. I think the messaging is a little bit different. It doesn't really work for me that often, but I try to make the messaging a little bit different that this is my immune system getting prepared to protect me from what's to come in the next several months.
And
so maybe go for it.
I was just gonna say, don't forget to remind them that there are steps we can do to prepare our immune system. If we were already healthy, we would be okay. But for most of us, we need to make sure that we're taking vitamin C, that we're avoiding sugar, that we're sleeping adequately. It's just that so many things that would help our immune system that we should be doing routinely, just for many of us, that's not our routine. And, that's speaking as an adult primary care doctor for real. But yeah, taking those steps that we were mentioning earlier about how to prepare, from my own experience and for my patients, I definitely have seen that help to reduce the side effects.
Right. Thank you both so much for your insight. I just always learn so much and really want to use this time to ask both Dr. Gates and Dr. Owen if you have any closing remarks for the audience on advice, suggestions, and just general takeaways.
So for me, I think I'm a pediatrician, so like my focus is on young people, and we have seen a change. We have seen more young people get it. We have seen more young people get sick. We have seen more young people being quarantined. So I think that really one of the things we've been focusing on, thinking a lot about, is how to do outreach to parents and talk to them about their kids, both so that they understand that while it's still relatively low risk, that low risk doesn't mean anything if you have a child who's really sick with COVID. And we've seen it right all over the country, parents filled with regret that they did not do it. They just weren't expecting their child to get sick. And we have seen children get sick, and we have unfortunately seen some children die from COVID-19. And like I said, though, it's, I don't want to be an alarmist and say that it's likely. It still remains relatively unlikely, but it's certainly not impossible. So really to think about, number one, the kids, and then also to think about, what are the implications if we don't really get vaccinated, especially in our communities that are predominantly people of color, right? So if the higher percentage of people who are unvaccinated, the more likely an outbreak in school is going to be. The more likely there's an outbreak in school, the more likely that we potentially may have to quarantine a classroom, quarantine a daycare, quarantine a particular school. So I think not only do we see the disparities in the vaccination, but as those disparities grow, it's likely that a disparity in our response and how we have to react to COVID is going to change as well. And it'll slow, I think, recovery efforts and school efforts in communities of color if we don't kind of see an increased uptake in our community soon.
Thank you. Dr. Gates, did you have any comments you wanted to add?
The only thing I just want to say is just recognize just how vitally and critically important each one of you guys are as a community advocate and influencer. I think that I've moved the needle more as a friend than as a physician. So meaning that this is not something to where people's doctors are overwhelmingly being the ones to change people's minds. It's really their friends, the people who they trust, the people who care about them, the people in their community. And so Dr. Owen and I are just trying to give you guys the tools to go in spaces to where we can't go. Because sometimes the moment you wear the white coat, the trust and the issues with trust, as Dr. Owen so beautifully articulated, they're there with good reason. And so just recognizing when we talk about 28.69% of our community, that's it. We got less than 30 people who are protected here in Sacramento. We're reaching a fever pitch, we're reaching a dire point. We don't have time to wait when we are about to be hit with cold and flu on top of COVID and Delta and kids going back to school. So just know that you're irreplaceable and know how valuable you are to these efforts, and that your conversations literally have the power to change lives. And we can't thank you enough for that.
Wow, those were powerful words. Thank you both so much. And Ms. Kim, if you'd be so kind to go to our next slide, I'd really just like to thank all of our partners that help us put this together. So one more slide, and this is actually the t-shirt everyone will be given, by the way. So again, please don't forget to sign in the chat. I think there's here are some information. Feel free to take a screenshot, as I also believe we will be sending some of these materials out to our participants for today, but just ways to get more information on how to be vaccinated. Next slide. And to all of our community partners, Sacramento County Public Health, Kaiser Permanente, the Center at the Sierra Health Foundation, San Francisco Department of Public Health, and Vaccinate All 58. Thank you all so much for your participation. We hope that you feel more secure and being a leader in the community and really being able to have these difficult conversations to lift the face of the community and get things back to a better sense of normal. So without further ado, I will let everyone continue on with their evening, and thank you all for joining us today.